All right, so welcome. As you can see here, I want to make sure you know about the upcoming grand rounds. Really excited that Emily Johnston's coming back. She's a recent graduate of our HEMONC fellowship, doing wonderful work in late effects and disparities, and then here focusing on COVID-19 in children with cancer, extending some of the really lovely disparities research she did actually in palliative care with Lisa Chamberlain and colleagues here. So excited to see Emily. And then the following weeks, we'll hear about the clinical challenges of Kawasaki's disease with some thoughts on COVID-19. And I'm sure you know that our own Roshni Matthews was one of the first, really, I think the first publication starting to make that connection between COVID-19 and Kawasaki. So that'll be lovely. In terms of some housekeeping matters, please note the text code on the left for your CME credit. And the text code is unique to each grand rounds. We'll be sure it's in the chat box for those of you who are just getting settled in. Next slide. Okay, our COVID-19 in Children seminar series is doing an amazing job every week of coming up with some of the most pressing questions and keeping us all up to speed. Delighted to have Christopher Longhurst joining us. He used to be here as the Chief Medical Information Officer and is now doing that at UC San Diego, but continues to be a good collaborator with us. And Natalie and Raj are going to assist with presentation. So very important topic. Next slide. And of course, in April, we'll have our annual pediatrics research retreat. And it's a little bit different this year, obviously, the needs of doing it virtually. But one of the nice things about the program, as I'll show you shortly, is that it's spread over 3 days. So hope that people can plan accordingly and make it to some of the sessions or most of the sessions. And it's a wonderful forum to hear about things from our trainees, as many of our faculty who've been here for a long time get up to date on their work. And of course, we always use this forum as a way of introducing some of our new faculty. The next slide. And then this here is the session. So the morning of the 19th, the afternoon of the 21st, and the morning of the 22nd. Next slide. And this is the committee that spends so much time and effort putting this research retreat together, all with Allison's help. But we have really nice spectrum of different kinds of research and a variety of the faculty in the department, and it's really a thoughtful process and bringing you a great program every year. Next slide. Okay, so it's my pleasure to introduce Nichole, who I think is known to all of us, our Chief of the Division of Adolescent Medicine, importantly, really a stalwart member of the program committee for Pediatric Grand Round. So thank you, Nichole.
Thank you. It's my honor to introduce our Grand Round speaker today. Dr. Nichole Tyson is a clinical associate professor of obstetrics and gynecology here at Stanford. She joined our community in October, so it's really brave of her to be here today. She joined Dr. Paula Hillard and Stephanie Sizak as part of the Division of Pediatric and Adolescent Gynecology. Nichole graduated from Tufts Medical School, then did her internship and residency at UC Davis Medical Center in obstetrics and gynecology. And for the past 20 or more years, she's been chief of pediatric and adolescent gynecology at Kaiser up in the Sacramento area. She is an active member of NASPAG and has sat on many of the leadership committees. That stands for North American Society of Pediatric and Adolescent Gynecology. And she's also on the editorial committee of the Journal of Pediatric and Adolescent Gynecology. So as you're going to hear, she's passionate about reproductive health, and we look forward to her presentation. The title is, It's Not Just Birth Control, Understanding Risks and Benefits and Helping Your Patients Navigate Contemporary Contraceptives. Okay, Nichole.
Thank you, Nichole, for introducing me. And hi, everyone. It's really nice to meet you all virtually, of course. So the title of my talk today is It's Not Just Birth Control, Understanding the Risks and Benefits and Helping Navigate Your Patients, or helping your patients navigate contemporary contraceptives. And a lot of this information is not necessarily going to be new to all of you, but I think it's just a really great way to sort of power up your armamentarium when we're helping our patients decide about birth control and optimize its use, not only for birth control, contraception, pregnancy prevention, but for all the wonderful things it does to make life better for patients who don't need to have periods and need to have acne and PMS. So we'll just dive right in. I have no disclosures. The goals today will be to describe the cancer risk reduction afforded by hormonal contraceptions, analyze the current evidence about hormonal contraceptives and depression, talk about a lot of the therapeutic benefits of contraception today, and we'll touch and compare some of the progestin IUDs available in the US, because I know that's a really common question, and we're getting more and more interest in contraception, which I think is just a glorious, or interested in the Larks in our teens, which is just such a glorious success story, in my opinion. But now I'm going to move my little view over here. So today we're going to describe, I just wanted to go through the outline because it's kind of a beefy talk, but I just want to sort of guide you through what we're going to cover today. We're going to talk about all of the cancer risk reductions afforded by hormonal contraception, really looking at the evidence to support this. And we're really not talking about all, because that could be a talk or two in and of itself. But I want to highlight the endometrial, colon, and ovarian risk reductions. And we would be remiss to not talk about the ever-phobic breast cancer fears and contraception. We're going to analyze contraception information and depression, because we're undoubtedly going to have some, publication that's going to confront our patients in the near future. So we need to be prepared. And then discuss some of the benefits of contemporary birth control, including suppressing periods, management of PCOS, ovarian cyst reduction, and everyone's favorite acne. And then talk about the side effect profiles, insertion experiences, and duration of efficacy of our progesterone IUDs in our country. So again, cancer risk reduction. Today we're going to talk a lot about the ovarian, endometrial, and colon cancer risk reductions. We certainly could talk about some newer ones that even are talking about reduction in thyroid cancer. And what we know, and I think that will resonate hopefully through this beginning part of our talk, is that girls, women patients who use hormonal birth control actually live longer. Longevity is improved. So here is a nice case for us all today. Janelle is a 16-year-old who's been referred to us by our friends at Pediatric Endocrinology and has a recent diagnosis of PCOS. Her maternal grandmother had breast cancer at age 58, and her mother, of course, is concerned about starting hormonal contraception, given her family history. So this is a really great study that I wanted to highlight. And I think there's just so much I could talk about. I honestly had to just figure out how to put all this into a slide or two for the sake of time. But this was a brilliant meta-analysis, systematic kind of review of hormonal contraception put together by Del Pup. And it was really in response to a very frustrating study that I will talk about in a little bit from the New England Journal about breast cancer risk and hormonal IUD, which many of you probably remember because it led to 1 million phone calls. But really what he did in response to that was really a critical appraisal of the literature. And he prepared this really concise summary table of key articles. And what it demonstrates is really that all three odds ratios are well below 1, indicating that using hormonal birth control is associated with a lower odds ratio of endometrial, ovarian, and colorectal cancer. And I think the key point, and this is something I say to my patients and their moms all the time, or parents, sometimes it's not just moms. For every 5,000 women years of use, about 2 ovarian cancers and 1 death under age 75 are prevented when you use hormonal birth control. I think that's just a really nice advisory to patients, and I don't think people understand or realize that in the lay public. And another great study done in the UK, Neville will appreciate that, by Dr. Iverson, is she looked at 46,000 women who were recruited to the Royal College of General Practitioners Oral Contraceptive Study. And they were recruited back in the late 60s and were observed for 44 years. And what they did is directly standardize rates of specific and any cancers that were calculated for ever and never users of combined oral contraceptives. And data were standardized for age, parity, social class, and smoking. And so this prospective review really demonstrated an incident ratio, which is basically a hazard ratio, showing that, again, the incident risk of colorectal, endometrial, and ovarian cancer are reduced in patients using birth control pills. So that's a very powerful study. Now, obviously, we don't have randomized control studies, but for this, I think it's just a super powerful statement. And we'll come back a little bit more to that study in a couple slides. As we shift now, so we know the cancer prevention, and now we're going to talk about the ominous fear that everyone comes to our office with about birth control and breast cancer. And I must have that kind of consult discussion 5 or 6 times a day when I'm dealing with prescribing hormonal contraception for bleeding. I just had it in the hospital yesterday for a patient with profound anemia getting 4 units of blood, not wanting to use any hormones for her menses because of fear of breast cancer. So I think there's some really great studies that we can turn to that are very high quality that can give us some really great guidance. So the first one is a case control study by Marchbanks. And he looked at 5 different sites, almost 5,000 women who were diagnosed with breast cancer, and they found no association between current and recent OCP use in breast cancer. And some more recent studies in 2010, 14, and 17 showed a very small increase in breast cancer use, but the absolute risk was very small. And again, a lot of these studies, they're not randomized control studies, so there are definitely methodological limitations. That's where I want the CC to correct me. There are some confounding factors that made these studies, less significant and maybe less high quality. So the 2010 Oxford Planning Association study followed. So these are studies I'm bringing to your attention because these are more of the high quality ones because they have very high power and they're following long term, which is obviously what you need when you're looking at birth control and cancer. And so this 2010 study, 11 years ago, followed 170,000 women over 40 years and found mortality among OCP users was lower for ovarian and endometrial cancer compared to non-users. And the really great part is these benefits continued for decades after OCPs were stopped. And they did find that the incidence of mortality from breast cancer, which was about 1,000 cases, were unrelated to OCP use. So again, that's where we're really neglecting the opportunity to take this captured moment with our patients to talk about what are these breast cancer risks that we're also afraid of. And they're risks like not exercising, obesity, overweight, alcohol use, smoking, not healthy lifestyles. I think those are all things that, we have those pockets of what we can control and what we can't control. Our genes, we can't, but our lifestyle a lot, sometimes we can. And so I think those are, I really do take this as an arena to say, this is something you're worried about. There's actually a lot that we can do versus this fear about hormonal birth control. And just alluding back to Lisa Iverson's study from England again in 2017, she again followed women for these 40 years and 1.2 million, 1.2 million women years of observation and found the relative risk of breast cancer in current and recent within 5 years of OCP use had a slightly increased risk, but this abated in 5 to 15 years after cessation. And several other smaller studies have also indicated that this risk may be slightly elevated during OCP use, but it abates within 5 years after cessation, which is very important, especially in our adolescent and younger population, as they don't get breast cancer at that age. So we're sort of seeing this overall, trend of whatever risk may be there, even if present, really dissipates quite quickly. And I think what's very significant about her study as well is that there were significant decreases in ovarian, endometrial, colorectal, lymphatic, and blood cell cancers, showing that the relative risk for any cancers in the lifetime was less than 1. It was 0.99. So again, hormonal birth control and cancer really should somewhat be put to rest, and we can talk about all the benefits versus the risk. And again, one of the topics that sort of always comes up as well, so-and-so has BRCA, or you're seeing them because they've been themselves diagnosed with BRCA. And I think this is the population we're actually missing optimizing hormonal birth control to help them. So I think in this really thorough systematic review and meta-analysis by Dr. Moorman, he dissected over 7,200 citations and really tried to identify the quality studies and came down to about 20, which is sort of telling that we can read all of these articles and we can see them in the news because they love to publish these. But when you try to identify the quality ones, we got down to 20 between 2000 and 2012. and reported the incidence of ovarian cancer and or breast cancer in high-risk populations. And ultimately, what was found was that the use of oral contraceptives and ovarian and breast cancer among women who are BRCA1 or BRCA2 mutations, the cancers are the same as the general population. So again, that's the same as should be underlined. And what they really found is that these studies demonstrated that OC use reduces the risk of ovarian cancer in BRCA1 and BRCA2 mutation carriers. And so that's where the real pickup needs to be emphasized, is that we can identify breast cancer quite early through really great screening techniques. And that's why most women today who have breast cancer get detected early, and who have access, detected early and treated, and are survivors. That's the incredible advocacy we see. That's not the same for ovarian cancer. We still don't have a great screening test. They're not picked up early. They're picked up quite late stage. And their survival rate, while improving, is not as great, obviously, as breast cancer, nor is their quality of life. So ovarian cancer is a really tough disease to live with. So when we sort of think about what we're preventing with hormonal birth control in this population, we're really preventing a very morbid cancer for which we don't have any screening tests. And so this is just like the study that kind of broke everyone's back. Is the New England Journal published this study about contemporary hormonal contraception and the risk of breast cancer. And what it was kind of interesting is it really led to a lot of great epidemiologists and colleagues and friends sort of mounting a response to this, horrible kind of misrepresentation of what we know. And it really clicked onto people's fear. And so I think I want to give a takeaway, because I think we're sort of like going back to where we had IUDs from the 1960s, and oh my gosh, they're going to cause fertility problems, and the Dacon Shield. So I still think we're dealing with some of the ramifications of this study 4 years later now. But basically, Morch and his group basically published the study with all sorts of sort of takeaways in the media about 20% increase and sort of this extrapolation of data. I won't go on and on, but basically they found ultimately there was one extra breast cancer for every almost 8,000 users a year. And what they found is that women that are 35 years or younger are really scared of breast cancer, but it came out they really have a very low baseline risk. They found 2 additional breast cancers for every 100,000 women years. And the reality is, taking away from this study is that the risk of breast cancer in this group was increased with longer duration of use, except again, the excess risk disappeared within 5 years. And there were very few breast cancer events and no events of risk in girls and women who used vaginal ring, the patch, the implant, or Depo-Provera. So it's very confounding that other hormonal contraceptives do not have sort of the same outcomes as specifically the progesterone IUD. And again, when sort of thinking about these scary studies as patients and as doctors, this study didn't control for age at menarche, breastfeeding, alcohol consumption, exercise, diet, or BMI on nulliparous women. They only looked at the BMI in parous women. The other interesting thing is that the study didn't take into account any prior hormones that patients may have used prior to getting their IUD. So it's a really tricky analysis. And this was, again, a prospective cohort. So with even large number of patients and numerous confounding factors, the relative risk was still quite low. And so, we have to sort of take these confounders as observational findings with a lot of caution. And so that's sort of the power that you have as an analyst of all of this data to give to our patients, to give them comfort and confidence. So yeah, that one study gets me going, obviously. So what do we say to our patients? We basically say that, yeah, there may be small increases in breast cancer among recent and current users. If that risk is present, it's very small and it dissipates probably within 5 years after cessation. And most patients are stopping hormonal birth control, when they're menopausal, most of the time, although we are continuing them for some hormonal management, honestly. And interestingly, we, not to digress, but we do know that women who use estrogen during perimenopause and menopause also are living longer. So hormones are not all bad. And I think those are hard messages to relay, but they're panning out to be quite true, and science is supporting that. It's just always going to be important for us to watch for alarming studies and confounders, because our patients are just seeing the headlines and propagating this sort of medical literacy fear amongst themselves. And one thing to think about is that we know that there's this inherent risk of breast cancer in women who give birth that can last for 10 years after giving birth. So there's already this baseline level that's increased for 10 years after you have a child. And we don't even calculate that into this sort of breast cancer analysis related to hormonal birth control. We can say there's no clear association between the LNG, IUD, and breast cancer. The risks may be associated with early diagnosis, which we know that patients who have access to healthcare and screening and get mammograms and get FNAs versus underlying biological causation. If there's a risk, it abates within 5 to 10 years. And overall mortality, I love number 8, is overall mortality and cancer risk diagnosed decrease with OCP use that lasts for decades, like 30 to 40 years after cessation. I think that's a very powerful, reassuring statement for our patients and each other. So, so I'm going to shift gears, and I promise I'll take questions at the end. I don't think I have very good access to the chat while I'm screen sharing. So save your questions up because I definitely will give us time at the end. So I'm going to shift gears a little bit and talk about, shifting from cancer to depression, which is another one we get all the time, this sort of fear and concern about depression and hormonal birth control. And so I wanted to take sort of a deep dive into looking at that and the quality studies that are available for us to talk about it. So I'm going to start with the case. So this is Leanne, a 13-year-old who came to see me for hormonal therapy. She has moderate to severe acne, and she started on a low dose OCP for acne treatment. Shortly after starting the pill, she had worsening depression, anxiety, suicidal ideation, requiring evaluation in the emergency department. Of note, this was before COVID. She stopped taking her birth control pill 6 weeks ago and noticed significant improvement in her depressive symptoms and worsening of her acne. And it's just difficult because it's not clear if it was the OCP that triggered her change in mood or a million other things that were going on in her life. So I think these are sort of things we're going to discuss as we sort of dive into this depression. So this is what we're all bombarded with in the news all the time. We see all these articles. These are in Teen Vogue, 17. It's just, everywhere. That's, oh my gosh, everybody's going to stop their pill because now you're going to get depression from this. But we're really not seeing balanced and science-based headlines. And we all know that's quite true. So there's almost like a conspiracy belief that birth control causes depression and serious mental health problems. And like somehow the doctors are in on this, and we're not telling our patients about it. Like it's some sort of conglomeration conspiracy. And I don't know if it's connected to public perception, or we also see this sort of in clinic as we get referrals from colleagues who say, I really don't want this patient to be on Depo-Provera because of her history of depression. And so I think that we all sort of need to break this trend, if you will, and really give our patients some good evidence and give each other good confidence of what we're doing. And I think hopefully after reviewing some of these studies together, you'll feel good about that too. So we know that estrogen has really profound effects on our mood, sex behavior, fine motor control, motor coordination, pain, all these things. As I'm of that age of maybe the 5-0, I can attest that estrogen does influence these things, and not having it can be somewhat impactful. And estrogen and progesterones interact with a large array of neurotransmitters and neuromodulators. And it's really naive to think that the neuropsychological effects of hormonal contraceptions are impossible or maybe even unlikely. But let's kind of dive into the scientific literature and see what we're looking at with contemporary hormonal contraception and mood changes. But I think without really understanding completely, you have to understand sort of the history of where this research and sort of misconceptions come from. So we're going to dive back into the 1960s, where, as you know, the birth control pills were started as a contraceptive in the 60s, and it had been available really for a few years before that for menstrual regulation, of which people were both using it for contraception sort of under the table back then. But within years, there was a rapid increase to millions of users. And the interesting thing to always keep in mind is a lot of our hormonal birth control kind of bad reputation comes from incredibly higher doses of hormones. So the progestins of those pills in the 60s were 10,000 micrograms of progesterone. Today they're 50, right, to 150. And the estrogens were in the 150 microgram range. Today's, as we know, can be low in the tens to sometimes will go all the way up to 50. And we always sort of like, 50. But those are really quite low compared to the pills that routinely were used back in the 60s. So on the left side of this chart, if you look at the progestins at the top, you can see they're kind of familiar, the norgestrel and the norethindrone acetate. And we see that those progestins, between 10 and 44% of subjects reported loss of libido or depression. And it sort of seems like a dose response relationship. The problem is this sort of trial that is referred to quite often, and I think is sort of stuck in the medical literacy of our world, is that it wasn't a controlled trial. The incident symptoms were detected, but loss of libido and depression were commingled, and symptoms are not really reported with specifics. There weren't diaries, there weren't controlled analysis they were complaining of, and there was really no survey or questionnaire. Over the period of the trial, almost half of those withdrew for side effects, and of those, at least one had a mood complaint. So when you sort of look through this study that kind of resonates to today, it's a not high quality study, but it sort of set the stage for future analysis, which we'll talk about. So in the beginning, I think it's just important to just talk right about Depo-Provera. Clinical trials and cross-sectional studies found that users reported depressive symptoms. In 1966, Sanghi looked at 563 Depo-Provera new starts and basically found that so that's right. So he looked at 536 Depo new starts and followed up quarterly for a year. He asked at all the follow-up visits about experiences with Depo and if they plan to continue this method in the future. And the incidence reports of depressive symptoms were more common among discontinuers than continuers at 3 months. But once that 3 months was up, it wasn't statistically significant after that. And then the Paul study was a national population-based study in New Zealand, where 12% of the users who stopped after one shot reported depression as a reason for discontinuation, which then that leveled off as reason for discontinuation among 5% of the users who used it longer than that. But they also found that Depo was used higher among Maori women and among those of lower income and education, and didn't control for all those confounders or even other factors that are independently associated with the outcome that they were looking at, which is depression. So again, sort of some tricky confounders that weren't included in this analysis. And then when we look at these 4 prospective studies, again, this is a talk in and of itself, so I just try to tie some of the strong literature together. And I know it sounds a little literature heavy, but again, this is to sort of, arm you up for discussion so you feel good about what you're advising or recommending. So when we look at sort of 4 prospective studies using actually validated instruments and some additional statistical controlling, they found no, and I emphasize no association or significant difference in depression among Depo-Provera users versus non-users or discontinuers. So there wasn't any difference between the user, the non-users, or those who discontinued. And when you look specifically at the adolescents, there's 2 prospective studies that found no association between adolescent Depo-Provera use and the incidence of depression at follow-up, and they looked at it from 6 to 12 months, which is great. And while we still don't have randomized controlled trials evaluating depression among Depo-Provera users, I think there's a lot of small studies that really talk about hormonal birth control as a whole, improving sense of quality of life, improving libido, and probably improving mood, attributed to maybe the sense that they're not fearing getting pregnant. They don't have the hassles of some of the problems they were having hormonally related before. So it's very complicated. But I think we can feel confident that, especially in our adolescents and the studies in our adults, with today's modern birth control, we're not seeing depression as impactful. So when we think about Depo specifically, which I think is the one that really comes to us with the stigma of depression, we can feel comfortable saying, today's validated instruments have found no association. And it gives us sort of a framework to critically look at older studies or newer studies even that come out. So I didn't want to not bring up, of course, our favorite Nexplanon. In terms of the studies based on this, a small proportion of subjects reported depression that led to discontinuation. However, there's no studies of the etronorgestrel implant users and depressive symptoms using any validated or reliable instruments. And of course, the other lark of our favorite panacea here is really not tremendous studies either in this arena. I think we have a great gap that could be a perfect arena for some research. But pharmacokinetically, it would make sense that the risk is much lower than would exist for other contraceptives, given the very low systemic exposure to the levonorgestrel. Most studies, again, using validated instruments have found no association between the progesterone IUD and the development of depression or depressive symptoms. And then in terms of hormonal contraception and depression, there's a lot of actually high quality studies looking at depression and oral birth control pills. Graham and colleagues did a study back in '95 and found no difference in depressive symptoms as measured by Beck Depression Inventory and Mood Self-Report between the levonorgestrel OCP group and placebo after 3 months. And then there's 12 other observational and prospective cohort studies that found either fewer depression symptoms, which is what I alluded to, and no significant difference or improved positive effect in oral birth control pill users. And there are many studies that look at route of administration, dosing interval, and progestin in the pill, and they all suggest fewer depressive symptoms and variation in mood have been associated with the use of hormonal contraception. So perhaps today's modern formulations and strategies are optimizing mood by stable distribution of hormones. I think we all are favoring monophasic preparations versus triphasic. No one wants to mimic the natural, menstrual cycle with triphasic hormonal fluctuations. And there are probably a lot of benefits to transdermal and transvaginal hormonal contraception as well in terms of stability of levels in our system. And perhaps there's some role, although we haven't really seen it in great studies, of the less androgenic progestin. So I think we've come a whole long way since 1968. And I think we can really say comfortably that there's population studies, which, are our favorite, of course, with all those confounders, may find an increased risk for prescription of antidepressants, which, is serving as a proxy for depressive symptoms among users. And these are sort of the studies that people tout. And there's similar fundings with the Skovlin paper that really talked more about the Mirena or the levonorgestrel IUD and Depo-Provera. But again, the problem with these studies that exactly made the news again and sort of resonate in the Google searches is that there's just so many methodologic flaws. The biggest measure is again, not looking at confounding factors. There's so many differences between the two groups that they're not really evaluating and accounting for those statistics. So the Skovlin paper, which was the IUD one, has really been skewered, which I'm glad. I mean, I think epidemiologists have really torn it up because they didn't control for confounders such as access to healthcare or problems with the measurements of exposures. And I think Skovlin really focused his energy on controlling for age, calendar year, education level, PCOS, and endometriosis, but sort of remiss for so many of the other factors that contribute to depression. And I think the other factor it's always important to take into consideration is that not all of these patients are using hormonal contraception for medical therapy. They're using it to prevent pregnancy. And, it's astounding the hormone level that exists in pregnancy can certainly contribute to depression, antepartum and postpartum. And so I think we always sort of are weighing the pros and cons of what we're trying to risk and benefit. And that really needs to go into our shared decision-making discussion with our patients. So lastly, I think we're going to really talk about two quick studies about hormonal contraceptives and depressions. And really the first was a nationally representative cross-sectional study looking at US female adolescents aged 13 to 18 that found a similar risk to the Skovlin study for OCPs, OR of 2.2. However, when they controlled for smoking and age, sexual debut, and socioeconomic status, the difference totally disappeared. And similarly, a study of women seen in the VA system, women who initiated contraception had a higher risk of depression, diagnosis, and antidepressant use, but the risk was null or attenuated when controlled for accessing healthcare. So it really suggests that healthcare utilization may have been a confounding in so many previous reports. So we just have to be very, very careful with these population studies and when they use surrogate markers such as prescriptions for antidepressants. So in summary, I think that, we've kind of beat this hormonal contraception vibe and depression to a nice summary, which is the preponderance of evidence does not support an association between depressive symptoms and contemporary hormonal contraceptives. And many studies actually show that it improves. And so following up our little Leanne, she decided to try a different oral birth control pill. And after 3 months, she reports her acne is already feeling better and she's in a euthymic mood. And I think that's a lot of our experience is let's try something different, whether it's another delivery system of the hormonal birth control or if it's a different pill altogether. And so we'll really never know what happened with this patient and many of our similar patients. It could have been that her depressive symptoms and suicidality were coincidence, by chance, starting a different pill. So I think that we kind of need to work with our patients and individualize, knowing that we have this great foundation in the literature of what we know is to be true. So I'm going to shift gears now to some of my favorite parts about birth control, which is talking about all these awesome benefits. And I won't even name all these off. You know them as well as I do. But we know that hormonal birth control is great for menstrual bleeding, irregular bleeding, painful cramps, underlying bleeding disorders. And the key point is it really improves women and all people's quality of life. So it's certainly not gender specific. We use that a lot in our gender care patients. And I think we're starting to see more and more of that as we work in that world. And I think it's really fun for me to read about modern applications of menstrual suppression. There's some great articles now about medically induced amenorrhea in astronauts. And I think it's really fun to share these with our younger patients to show, this is how we're powering up modern day women. And I think when you think about astronauts, these patients, these women need reliable contraception. They work in terribly austere environments. They often have a long history of using menstrual suppression, much like many of us physicians. Like just thinking about stocking pills for astronauts on a 3-year mission, and how are you going to change your tampons and pads and trash capacity? And you really start thinking about opportunities for menstrual suppression with things like Larks. And I think that's a huge plug to our younger patients who are so conscientious about the environment, is that not having periods is actually really wonderful for the environment. We don't need to use so many disposable paper products. This is just a really nice slide I give to all of you to sort of keep handy for your counseling. We've made some really great handouts for our patients in our hematology, gynecology joint clinic for sort of the patient-facing material. But I like these because it has an image too. And some of these I'm going to kind of go through sort of quickly as these are sort of, all of this, but I think I just wanted to be sure to add this to our slide deck here, is the great importance of hormonal contraception, oral contraceptives for treating abnormal periods in patients with PCOS. It's particularly good at treating hirsutism and acne, which I'll cover acne in a few slides too. And we know that Depo-Provera is also a great option because it really is sustained enough levels to suppress gonadotropins. We know that birth control pills are great for suppressing ovarian cysts, as are the patches and the vaginal ring. We do want to always clarify to our patients that it's not necessarily going to make this cyst that you may be here seeing me for go away, but it can prevent future cysts from forming down the road. And one really interesting application is there was a nice study that just came out this month in our little Pediatric and Adolescent Gynecology journal about maybe women with one ovary have hypertrophy of that ovary, sort of to compensate, like we see with one kidney. And maybe that higher growth, if they add to a cyst to that, maybe a higher susceptibility for torsion. So yet another role for using hormonal contraception to help preserve that one beautiful, healthy ovary in a patient who might only have one. And again, to talk about birth control pills and how they improve acne, I think it's nice to explain this to patients. And I must have been a little silly when I made this slide because I made it all animated. But the pill works on many levels. And I think that's how we can induce some patience in our patients, like to have the tincture of time to support hanging in there, is the pill directly opposes androgens at the local level. It actually regulates genes involved in the sebum production and sebaceous gland growth. It also provides negative feedback on the pituitary and hypothalamus. It inhibits the anterior pituitary's production of LH and FSH, and this ultimately goes back to decreased ovarian production of testosterone, which is what we want. And then we all love the sort of Pac-Man visualization of the sex hormone binding globulin, which is the one that takes a long time when you're starting hormonal birth control to kick into gear, which ultimately binds the testosterone, decreasing the free testosterone, and then decreases the number of androgen receptors, and really is an awesome modality for treating acne. Is there a best pill for acne? We get this question all the time. Probably not. I mean, when we look at these Cochrane reviews of all these different methods, again, they're not fabulously elegant studies, but probably all the birth control pills used are great for acne, and how they compare is really unknown. We just have one trial and that didn't show a great difference. I think advertising is fantastic. And we know sometimes when patients come in with an option that they want, they're sort of happier when they get that. I think there's probably a really good one with a different estrogen that we have in our country that maybe will come in other countries, but in America and the US, we really can say they all work fabulous. You're going to be good with the pill. The IUD in acne, I think this is something that comes up a lot. Is I've actually had dermatologists say you need to go see Dr. Tyson and get your IUD pulled because it's causing your acne. It's important to know acne is only reported in about 13% of IUD users, but again, not so much disruptive to discontinue. It's only in 1.3% of our patients. So the thinking is acne probably is not caused by the IUD, but since the Mirena is only progesterone method, people often switch from the pill to the Lark and then can experience acne, and then they attribute this flare to the new contraceptive method. But it's simply that they're no longer using the pill. And similarly with the implant, it's very much like the progesterone IUD. Some complain of acne, but only very few discontinue it. So what do you do with these girls who have acne with a Lark? These are the ones I'm not teaching to self-remove their own IUD. I encourage them to keep the IUD for what they're using it for, their Nexplanon, if it's for birth control, if it's for bleeding, it's for cramps. But then let's talk about what we can do to help your acne. And sometimes adding a pill or a ring or topical acne treatment or antibiotics, and all of the panacea we have to manage acne. And there are many patients of mine who I do have on a pill or a ring with their IUD, and they do great for their bleeding profile and their acne. So another quick case is you're busy working in your busy adolescent clinic, and a patient wants a same-day IUD and her implant removed, and your excellent trainee inquires about how you're going to counsel your patients. And I think these are fun visits. I love sort of talking about Larks and optimizing Larks in our patients. And I'm going to share this nice screen so all of you can keep it for later. I think it's just a nice depiction of what we have in our country in terms of our IUDs. I think we're seeing so many now, and what colors their string, and patients sometimes don't know what they have and how long it lasts. And so I think this is just handy to keep. And I think to summarize, again, this is a whole talk that we could give about the various progesterone IUDs. But when we're talking to our patients, they've often read something like, you need this super cute one because you've never had a baby. I think we can counsel them and sort of guide them onto better education and help them pick one that might actually be fitting for them. People typically have more bleeding and spotting days with Skyla and Kylena. They are slightly smaller in that they release lower amounts of hormones and effective for fewer years. There's really few millimeter difference in size from the prior slide. You can see that. And most people do fine with the insertion of all the IUDs. And really, when you break down, there's not great studies. I think there's anecdotal stories that these smaller IUDs are easier to put in. And I think that they're certainly advertised robustly in that arena. But most experts, really, there is no proven difference. And I think we all sort of have our favorites and what we get used to. But they all are very reasonable and very similar. And there's just so many factors that go into pain with insertion with IUDs. And I think I placed them in my office in girls as young as 13, who was delightfully easy compared to some women I've placed when they're 45, and all of us are losing our minds. So I think it's a lot of factors that aren't just about millimeters in size. They all have great beneficial treatment on dysmenorrhea. And I think when you're counseling about goals of amenorrhea, then you sort of can see the difference because related to the levels of progesterone in the IUDs. So basically, Lyletta, sort of the Access IUD study, the levonorgestrel release rates from Lyletta are similar to the Mirena. It's the same product. The price is so much less expensive. And this is a huge sort of financial saver to the industry. It does have this single-handed slider that is a little different, but I have heard this summer they are promoting it and advancing it, and we're going to see something new and exciting coming our way. So I do want to wrap up and give time for questions. I'm going to give a few more slides, just a summary. Adolescent contraception, keys to success. IUDs are safe and effective. We should always talk to them about extended use. We've got to really try to focus on our same day insertions. We have an awesome, fun little bell that we all take pride in ringing in our adolescent workroom, which is really fun. I love that. Always talking about the non-contraceptive benefits are important. While birth control or unplanned pregnancies have gone down in our country, there are little pockets where we're not seeing that change, and we're right next to one in Salinas, for example. So I think a lot of patients will come see us for non-contraceptive indications, bleeding, cramps, PMS, and I think we need to also talk to them about sexuality and unprotected sex, and they're probably sometimes seeking birth control, but coming in a safe space with some other complaints. And we're seeing this expansion of Larks, as I alluded to earlier, in the arena of menstrual suppression for adolescents with developmental delays, transgender or gender diverse individuals. I think there's a big population of patients that we really can expand in growth for Larks for making their lives better. They don't have to just be astronauts. The implant's just one of the most awesome reversible contraceptives available. It's the most effective. I think we all brag about that to our patients. Insertion and removals are very, very easy and brief. We see the uterine bleeding. We know that it's going to happen. Anticipatory guidance helps retention. Always reassuring that we'll remove them whenever you want. Even if they do have spotting and bleeding, they don't have cramps with that. And for many patients, that's just a sheer joy. Always looking at the bleeding irregularities in the back of your mind, like, is this chlamydia? Is there something else going on? We don't want to ignore. And again, extended use for up to 5 years is super important. And we've been seeing this really growth and expansion of that with access limitations during COVID. Depo Provera, we've also seen some changes in COVID. We can extend the window up to 15 weeks. And for many patients, we'll actually give it early too. Some girls will have spotting, or their seizures will return before they're due at their 12-week mark. So having agility with these patients, it doesn't have to be strict. And you can also keep in mind that some of them are not using it for contraception. So it doesn't mean you can't get it if you're late. Some great birth control clinics in the Midwest and Ohio has a BC for You, where they're doing drive-up Depo. We also had a drive-through Depo clinic in the Kaiser where I was working. The sub-Q Depo protocols have really expanded. I have yet to prescribe that here, but I've had several patients inquiring about it. So I'm going to look into that with their insurance as well. You don't need DEXA screening. Healthy users can continue well beyond 2 years. We do know that nursing administrative protocols really help the patient experience. And then routine surveillance is still, basically all these girls and patients of ours should be using calcium and vitamin D and talking about weight moderation. And birth control pill key summaries here. There's no minimum age to start. You should have a menstrual cycle, and then you can start your pill. I'm a super fan and advocate of monophasic pills. I'm a super fan and advocate of so many of the residents and fellows who've worked with me to suppress periods by skipping pills altogether, really encouraging patients to understand mortality and cancer risk reduction. And birth control pills are not contraindications or indicated in patients with family history of breast cancer. So in summary, we can really feel good about providing hormonal birth control for our teens. And I think they really provide a lot of empowerment for these various chapters of a person's life. They don't have to, go to college. They can go to the moon. I think there's just so many great things about hormonal birth control. So thank you very much. And I wanted to conclude with some last resource slides. This is a really cool article that just came out this month about this tangible decision aid tool supporting patient-centered contraception counseling with young adults. So I'm going to figure out a way to get some of these for us because I love it. I like the hands-on look. And it actually showed that teens, they're the ones who put this together and they liked it for counseling, and it made a big difference. So I think we all have our little strategy and techniques, but I might get this little special ring. And then here's some nice resources for patients. If you haven't heard about some of these websites already, I think they're really great and helpful. Thanks Birth Control, everybody loves that. Sexetcetera.org is a really fun one for teens, and it's made by teens, and questions are answered by teens. Scarletine, which is not being updated, I've been realizing, which is a bummer. But I think it's a great website and it still exists. And they have this great birth control bingo that sort of helps teens figure out which birth control is right for them. They love all these, like, you know, like the quizzes and Quizlets. And so I think this is a really fun one. I used to use this when I taught sex ed to teens, because they're all into Quizlet and they obsess about it and compete. So I just would do birth control bingo and see who would win. And here's some really great adolescent contraception articles, all out during COVID time. Everyone's been busy writing. And I think this is just a really great article put together by a bunch of my colleagues about the provision of reproductive health for teens during a pandemic, because this was also a very unique time, right, for all of us. So I think that is the end. So I'll stop sharing and I will take some questions.
Thank you very much. That was a wonderful presentation, and hopefully you've helped dispel many of the myths out there. I've been monitoring the chat and there are quite a few questions. One is, and this is not from me, can you touch a bit on the impact of hormonal contraceptives on bone density and bone formation in young women, in particular when navigating contraceptive options for patients at increased risk for bone density, such as Crohn's disease, a history of amenorrhea, etc.?
I think that's from you.
No, it's not from me.
So I think, you know, as I've learned from Dr. Golden and Paula Hillard, is that we do want to be cognizant of these low dose hormonal birth control pills and the low. I think because everyone has this cancer fear and they're so afraid, they figure we'll just go low. We'll go to these really low doses. And we've long known that when you do that, these girls with very healthy livers and robust metabolism break down these pills and spot all the time, and it just doesn't promote longevity of use. And we're finding it's not good for their bones either. It's not enough estrogen to sustain healthy bones in the time that they're forming their good bones. So I am not a fan of anything 20 microgram or below. I am a huge fan of 30 microgram and above, and I will often use 50 micrograms in patients who are breakthrough bleeding a lot. So I think that is something to really think about when you're sort of dealing with these shying away. I want these low dose pills, and that's how they're advertised. Are you concerned about hormone levels in your body? Then you should get the low dose. And I think one thing you can sort of divert to patients who still, like, we can counsel all we want, but we know what patients feel and fear. The vaginal ring actually has the lowest systemic levels of the pill, patch, and ring. And many patients, I have very young patients who you wouldn't think would use a ring, are very, very happy with the ring. And it does keep a nice sustained level of hormones. So the ring is effective for 35 days. So I routinely prescribe the ring for a month for continuous use. And you will sometimes get pushback from the pharmacist where you can say, actually, it's effective for 35 days. Month-long use is totally fine, continuous use. And you just have to prescribe a few extra rings so patients don't run out. So that's a great question.
There are a couple of questions here about the effect of estrogen in oral contraceptives. One is, can you comment on the risk of thrombus formation in estrogen-based birth control for cardiac patients? And then also there are a couple of questions about migraines, and one specifically that says, can you please talk about how you counsel patients with migraines with aura who would benefit from estrogen? It seems like the research on this is old and with higher estrogen doses.
Yeah, Hecky, those are really good points. I think in terms of thrombosis, it is always very tricky because patients, you know, the family members may have some sort of blood clot, and we really do have to sort of dig through and dive into that a little bit, because we're talking sometimes about 14 and 15-year-olds. You don't want to stigmatize not being able to use estrogenic hormonal birth control their whole life. And again, thinking about what are we thinking about too when they do want to have a pregnancy, or if they do, and planning a pregnancy. So I think exploring the thrombosis history is really important, figuring out who's got the thrombosis, what was the thrombosis, was it related to a hip fracture in a grandma? Because that's a whole different story than if someone, you know, has factor V Leiden and their mom had a pulmonary embolism. So sometimes I work actually with genetics to talk about it, and I will order some blood tests to work up thrombotic diseases. So hematology can also be helpful. I think in these patients in our younger population, I think it's worth the investment to, number one, either reassure them that it's safe versus, finding out that there's a problem so that you can actually plan ahead. I've seen both. I mean, I think a lot of the times, anecdotally, probably 75, 80% of the time, the thrombosis has nothing to do with my concern with using hormonal birth control. And in fact, if they're trying to prevent pregnancy, we're still dealing with way higher doses of estrogen in a pregnancy than any hormonal method. But again, so you can either help them feel comfortable using that hormonal method and or identify a serious problem that can help really take care of them preconceptually. So that's a really important one. And the same with like these sort of complex cardiac kids is sort of talking with their cardiologist to see what is their thromboembolic risk. Because when we use our CDC medical eligibility criteria, it's a little bit vague. Is it complex? Is it not complex? And I think some of our patients, particularly here at Stanford, it's hard to tell if they're complex anymore. And you're really looking at what is their thromboembolic risk, and you need help sometimes from the cardiologist to clarify. And I find that we're the ones educating the cardiologist. We're like, yeah, that sounds like a cardiac problem, but that doesn't necessarily put her at thrombotic risk. So let's talk about that. And again, when you're really sort of in a bind or you don't have clarity and you need something now, then progestin only methods are always great because the thrombosis is due to the estrogen, not the progestins. So that's something you can kind of talk to your patient while we work this out. Do you want to start this, a Lark or progestin only pill or a Depo shot? And the migraine with aura, I think is sort of the same. Yeah. So that's the same thinking. I think these are the girls you really want to nail that down early because it's frustrating right now. It is a contraindication. And I keep waiting for these new guidelines that we hear because it is kind of old data and it is super impactful because a lot of patients say they have migraines with aura. There are times where I'll work with neurology to really see if it's a migraine with aura. I feel good diagnosing what a migraine with aura is. I mean, there's really some good headache guidelines. I can email those to you. I think it was Dr. Miller too. So those are ones I want to decipher and figure out. Because I think a lot of times we'll see these girls with migraines with aura and they have a sinus headache. And we're stigmatizing the whole panacea of birth control for them. So I'm with you. I think the migraine with aura risk is a tricky one in these young kids who are very low risk of having a stroke. And I think while it's a contraindication, I think it's something, to explore and talk through and individualize.
I think we have time for one more question, and I'm going to lump two questions about IUDs. The first one is, what can we tell adolescents about future pregnancies, uterine damage, etc., in some patients with IUDs? And another question related to that is, what are your thoughts on some women blaming Paragard and copper poisoning for all sorts of problems, bloating, GI problems, etc.?
Those are good questions. There is no future fertility concerns with today's modern IUDs. So I think we use IUDs, one scope that I tell them is we use IUDs as a gold standard for treatment for endometriosis, and endometriosis can cause fertility problems in the future. There's also evidence that the progesterone IUDs can reduce your chance of PID. Not that I want them to go off and have promiscuous sex without condoms, but the reassurance that the IUD is probably protective, not damaging. And I think they should feel very comfortable and happy about using that IUD and feel safe that you take the IUD out, it clears your system in 24 hours and your fertility returns to baseline. And the copper poisoning, I know, that one's a killer. I have patients who will not get their IUD because the button on their pants, the copper in their jeans gives them a little redness. And there's really no evidence to show copper poisoning from the Paragard's IUDs. They've been used around the world for decades. They're primary contraceptives in many parts of the world, just not here. And we would have had astounding numbers of case reports, and we would have been able to see this data as it's been followed. So I try to reassure them. That one's a tough one, but that one just is really unfounded, I can comfortably say.
Okay, it's 9 o'clock. Thank you very much, Nichole. That was a wonderful presentation. And I want to thank everyone for attending Grand Rounds today, and we'll see you next week.
Thank you, everyone. Nice to meet you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.